You're listening to Decoding Healthcare Innovation with Carrie Nixon and Rebecca Gwilt, a podcast for novel and disruptive business leaders seeking to transform how we receive and experience healthcare.
Hi, everyone. I'm Carrie Nixon. Thank you so much for joining us for the next episode of Decoding Healthcare Innovation. I am really pleased to be joined today by Kyle Zebley. He is the Vice President of Public Policy at the American Telemedicine Association and the Executive Director of ATA Action. So he is wearing two hats, and he'll tell us a little bit about both of those hats today. But before I start, I just want to say that if you don't know the American Telemedicine Association, you really should, because it is a great organization and a real powerhouse in advocating for virtual care and virtual care management and digital health policy. I can definitely say that their work has helped to move the needle for digital health and for telehealth sort of across the board. And they are very committed to expanding adoption of digital health and telehealth technologies. So prior to joining ATA, Kyle was the Chief of Staff in the Office of Global Affairs at the Department of Health and Human Services. He worked in all kinds of interesting areas like drug pricing, medical devising, global health security, non-communicable diseases. But he also spent some time in Congress as a legislative director and has really earned his chops with a great DC policy pedigree. So, Kyle, let me turn it over to you to add anything that I've left out, and then we'll kick off our conversation.
Great. Thank you so much, Carrie. It's a real honor to be here. And of course, I get to work with you on a really regular basis. And obviously, you and your team are truly second to none in the expertise that you bring to public policy and also to the laws and regulations concerning telehealth and its implementation. So when you
thank you. That was a requirement in order to join the podcast, for sure.
Well, I mean it because it's true, and so easy things to say, and it is a real honor to be here with you. The ATA is obviously at a really exciting moment right now. We've been around since 1993. But the last couple of years during the pandemic have really kicked things into high gear for the industry. And I know you had been at this for a long time, even before the pandemic, before telehealth became a household name. But for me, during my 10 years in government, telehealth was frequently brought up as a notion, as something that was going to be out there in the future, and it had the capacity to change healthcare. However, it was always something talked about in the future tense. It was very rarely talked about in the present tense as something that was happening now. And so during my time at HHS, I obviously had a lot of activities in a lot of different fronts, talking to other ministries of health, working with multilateral organizations like the World Health Organization on a whole variety of fronts. However, when I heard in the summer of 2020 that Ann Johnson, our CEO, was looking at somebody to lead the public policy efforts at the ATA, I had to throw my hat in the ring because I knew that telehealth was really coming of age, was really at the front and center of the response to the pandemic and ways to change healthcare now in the present, finally. And so I was really honored to be able to have this opportunity to work with our members to change the face of U.S. healthcare. Have been here, like I said, for just over 2 years. The beginning of this year, we actually launched an advocacy arm, a 501c6 in the tax code that removed all limitations that we had in the ATA's model of being a 501c3, so that we could be as active as we needed to be in the advocacy and lobbying space.
And that's so ATA Action, is that right?
That is absolutely right. Excellent. And that's why I'm very much in that classic DC sense, a double-hatted employee of both ATA and ATA Action.
Excellent, excellent. So that's great background. So Kyle, before you and I had even talked about doing this session, or not too long after we'd started talking about doing this session, we had a bill passed in Congress that I think is going to have some pretty significant implications. And that bill was passed, I believe, just last week. It's called the Advancing Telehealth Beyond COVID-19 Act of 2022, and it has passed the House. Can you talk to us a little bit about the significance of this bill? It's HR 4040 for any of you who are interested in, scrutinizing the details. Talk a little bit about the significance of this bill and what comes next for telehealth policy.
Well, absolutely. Thank you for that question. And it is really top of mind for the telehealth community because a lot happened just in the last couple of weeks, and it all came about all of a sudden. But I think it's due to the collective efforts of the community and folks like you, Carrie, and folks like other members of the ATA, and of course our public policy team. So what happened was we got word the week before last, right around mid to late July, that Democratic leadership were interested in bringing a bill to the floor that has been sponsored by Congresswoman Liz Cheney. And she introduced this bill last year, and obviously something that we were supportive of, but we really had no indication until just 2 weeks ago that it had any chance of being brought to the floor. And unlike the original version as introduced, the version that ended up coming to the floor was a 2-year extension. As introduced, it was a full permanence, but this version is a 2-year extension of a variety of the flexibilities that came about, in particular in the Medicare program, in regards to telehealth since the beginning of the pandemic. And it's the second major action taken by one of the two chambers since the beginning of the year. Earlier this year, in an omnibus federal funding bill, we got a number of telehealth policies included that allows for an extension for 151 days post the public health emergency.
Right.
And the extensions we're talking about are the geographic and originating site restrictions that have been lifted during the pandemic, the ability for federally qualified health centers and rural health clinics to cover and get reimbursed for telehealth, audio-only telehealth services, forestalling the implementation of this telemental health in-person requirement that many of your viewers might be aware of. So we got 5 months post PHE earlier this year. This new Cheney bill would be for 2 years, until the end of 2024. It passed overwhelmingly, despite some concerns among some, particularly in the Republican side, the minority side, about process and how quickly it was brought to the floor. We got 416 votes to 12 in support of this bill. No consternation about some of the things that we hear from time to time. Yes, telehealth is a universally popular, bipartisan, bicameral area for both political parties and both the last administration and this administration. But sometimes you hear some concerns about cost or fraud, waste, and abuse, program integrity, et cetera. None of those concerns were brought to the surface in earnest, and we were able to get this landslide win.
So you're saying we actually got a piece of bipartisan legislation passed?
Well, passed in the House.
In the House.
Now
it's a step.
Up to the Senate.
Yeah.
Exactly. An extraordinarily important step. And no matter what, they can't take away the 416 to 12 vote, which was really of historic proportions. Now it sits with the Senate, and hopefully the Senate will take action.
Yeah.
And so it's certainly a very exciting moment for the community.
Yeah. So I think it's an enormous step. And actually, I'm going to take a step back for a moment and just kind of give a broad perspective, in case there are any of our listeners who aren't quite as familiar with sort of the timeline and the history of telehealth in the U.S. as others might be. So very quickly, Medicare is the largest payer of healthcare, certainly in the country. And Medicare, when it sets policies, a lot of the other payers tend to follow those policies. And so back in the late 90s, Medicare said, wow, there's this new thing, this new technology, which allows us to connect people in rural areas to specialists in the big cities when they need healthcare of a very specific kind. And so we're gonna reimburse for those services. We're going to reimburse the provider who is in the rural area at a rural health center with the patient. And we're also going to reimburse the specialist for, in the big city for the care that they're providing. And believe it or not, that was sort of the state of legislation around telehealth until the pandemic. We absolutely had a system whereby telehealth was only reimbursed by Medicare in those very, very limited circumstances, regardless of sort of the advances in technologies that we've had. And, hard to believe, but there had been lots of little, nitpicky policy fights and debates, Kyle, that you sort of referenced prior leading up to that. But then the pandemic came and all of a sudden everyone's like, we got to get virtual care out there. So fortunately, things have expedited a bit. And, I have recognized with my clients that we serve here at the firm that this uncertainty around what's going to happen with telehealth is problematic, right? It makes companies and providers hesitant to not only adopt, but to innovate additional technologies around virtual care services if they're not really sure that they're here to stay. How do you view this legislation? In that context, is it going to provide some certainty to give some comfort to these companies and to providers who are doing virtual care services?
Short answer is yes. Certainly more certainty than we have now. Even with the changes that our law that passed earlier this year in that omnibus that I talked about, that's only 5 months, and that it's tied still very specifically to whenever the PHE ends. That 151-day clock starts counting down the day after the PHE ends. This piece of legislation gives us a calendar year's worth of certainty.
Yeah.
December 31st, 2024 would be, all these flexibilities would be in place until that date. Obviously, our number one starting point, if we had the keys to the kingdom, would be permanence.
Yeah.
Because at the end of the day, these provisions, I believe, are going to be made permanent. However, Congress oftentimes kicks the can. And this is not a derogatory statement about any leadership. It's just the dynamics and the structural disadvantages of our current system. Yeah. They go through the path of least resistance. And so we've lived under these flexibilities now for 2+ years. All the community is asking for is certainty that it's not going, that the bad old restrictions that you mentioned so well aren't going to come back anytime soon. We think that makes a lot of sense to make them permanent. And if not permanent, let's at least do as long an extension as we can. And this is probably the best offer we'll get from Congress, at least for the next, the remainder of this current Congress, which will end in the beginning of January.
Yeah, and you mentioned earlier that this passed without a whole lot of bickering back and forth over the details of some of these issues. So, for example, payment parity is one of those issues that people have very differing points of view on. So, should telehealth services be paid at the same rate that an in-office visit would be paid as? My personal feeling is yes, for what it's worth. I think that when you have parity, you're going to actually incentivize adoption. But I mean, Kyle, is that one of the reasons that we sort of have this 2-year test period? Like, what is Congress going to be looking at during this test period?
Right. It's always exactly. The question is always more data. And I think that one of the issues is this does cost, and we've been able to bring the cost down. But having this kind of access to virtual care available to all Medicare beneficiaries does come with a cost. We brought that cost down because I think we're seeing more of what telehealth will operate like in the Medicare program during normal times. And that's actually one of the reasons why I think we've got this extension, because certainly 2020 and a good portion of 2021 are arguably, the data that you're going to collect during that time at the height of the pandemic, when a lot of the economy was shut down and the economy was finding new footing in a different world, frankly. I think that's a little bit of an asterisk set of data.
Not normal.
Data and exactly. I know. And so I think they're interested to see what the true utilization and uptick of this being a part of the Medicare program for that sustained period of time as the economy gets to be a little bit more quote unquote normal, as the society starts accepting the pandemic has turned into something endemic. That is probably one of the reasons. And they'll want to continue to do studies about whether or not there's any more likelihood that telehealth is prone to fraud, waste, and abuses compared to in-person care, even though we know so far that's not the case. It's no more likely. And also, again, I think the issue of truly, at the end of the day, what is this going to do to the cost? We think it's substitutive in lieu of care, not additive care. But I think policymakers want to take the time to see if that's really the case.
And that look at cost has to come through a longitudinal long-term lens, right?
Right.
There is an element of expanding access to care that, yes, is probably going to lead more people to get care than otherwise would have, but that earlier care is going to lead to reduced, lower costs overall. That's sort of the theory, right? Because you're going to be able to identify problems earlier. If it is easier for someone to do a telehealth visit from their home, maybe just taking a brief step away from work, instead of driving a distance, finding parking, sitting in an office, coming back. If that's going to, encourage someone to to get healthcare that they otherwise would have just sort of said, well, I don't have time for this, and kind of let it linger, you've got sort of that longitudinal aspect.
That's absolutely right. That's why the telehealth community is just about universally for value-based payment, which takes into account the preventative care that telehealth does so well. And of course, you talk to any medical professional and they'll tell you that if we're going to derive savings from this very large part of the U.S. economy, coming up on 1/5 of the U.S. economy, all of the U.S. healthcare spending, you're going to need to do the efficiencies that telehealth does well. You're going to need to make sure that there's a correct match of the patients with the provider needs, regardless of where that patient and the provider is physically located. And so we're going to need technology. We're going to need virtual care to drive these savings. And that's why we need to make sure that we keep the pressure up, and that patients that are relying on virtual care keep the pressure up, because we're not just talking about Medicare, though this is a set of policies regarding Medicare, largely speaking, when we talk about the HR 4040, because as you said so well, where Medicare goes, so goes the rest of the payers. What's included in the annual physician fee schedule for Medicare Part B fee for service tends to be a level set for what other Medicaid payers and also commercial payers are going to be covering and reimbursing for.
Okay, so we talked about what's positive about this bill, HR 4040, and there's a lot that's positive about it. Did they leave anything out, Kyle?
Well, yes, they did, and we're still obviously extremely supportive of it. But there are several provisions that are benefiting Americans now, that are now current policy during the pandemic, that have not been included in HR 4040, the Congresswoman Cheney bill. For us, that includes a really important issue that affects so many really vulnerable Americans, which is the Ryan Haight in-person waiver for the remote prescription of controlled substances. In essence, during the pandemic, in-person requirements have been lifted for that remote prescription of controlled substances. That's federal law, but in order to make sure really vulnerable communities are receiving mental health care and substance use and opioid use disorder care, they've been able to more easily have as accessible to them remote prescriptions of controlled substances. That's been left out. And so that wasn't included in the omnibus that was passed earlier this year as well. It has its own unique dynamics that we could talk about solely for the next hour or two. However, it wasn't included, and we know that Congress needs to act if we're not going to leave those communities behind. There are also 35 million Americans that rely on high deductible health plans for their coverage, and they've had a very favorable tax provision that have really induced them to use telehealth during the pandemic. And we want to make sure all 35 million of those Americans continue to have access to it after it expires, and it will expire at the end of this year unless Congress takes action. So that and a few other issues are definitely something that we'd want to make sure Congress knows about, because yes, we should pass this into law, but your work isn't done. There's more to do in the virtual care space.
Do you think that there are chances that the Senate would pass a bill that included provisions around Ryan hate and so on, or do you think that would be, almost a poison pill and sort of a deal killer?
I don't think it's a poison pill at all. One of the dynamics, which is less of a public policy dynamic than a strategic and tactical dynamic, is, obviously if the Senate were to amend this, it then has to go back to the House. And so that adds an additional step. But obviously we want to see Congress take action. One of the things we've heard about is perhaps the Senate will contemplate rolling up the policy provisions of HR 4040 in some other broader must-move package, perhaps in the lame duck towards the end of the year after the election and before the new Congress is sworn in. If they do that, and it's already being bundled up with other policies, that is a great time to add these important provisions.
Interesting. Okay, got it. All right. Well, Kyle, you mentioned the Medicare Physician Fee Schedule that comes out each year, and it's very, very important in sort of setting policy and reimbursement for the coming year for medical services, physician services. The Medicare Physician Fee Schedule came out just a couple of weeks ago. What are your impressions of the proposed fee schedule? We've got comment periods before it gets finalized, but what are your early impressions?
Well, again, the level set for your audience, it's just an extraordinarily important rule that has to go through the normal rulemaking process every year. And like we had talked about earlier, it really does guide not only how Medicare Part B will cover telehealth services for calendar year 2023 is what we're talking about, but it's also going to be a real bellwether for how other payers are going to be covering these services. A broad impression is that, once again, it does show the positive momentum, the real gains that we as an industry have achieved over the last several years. It has added additional temporary telehealth codes until the end of 2023 for coverage in Medicare as they contemplate, CMS contemplates making it permanent. It takes on board the 151 days of flexibilities that we talked about earlier. So that those will be seamlessly integrated for all Medicare beneficiaries in terms of what's covered for them and what's reimbursed for these beneficiaries. It continues the expansion of remote monitoring technology through additional remote therapeutic monitoring codes. And obviously remote monitoring is at the cutting edge of delivering virtual connected care. And so that's obviously most welcome. There are some real disappointments, and I would be lying if I didn't mention that, and things that we'll include in our comment letter, and that other advocates for virtual care, I'm sure, will be hitting on as well. We're worried about restrictions for remote physiologic monitoring that have existed for years, such as one particular requirement that says that you have to have 16 days worth of data before you can get reimbursed for RPM coverage. That doesn't take into account lots of use cases that are really commonsensical. So it's very limiting in its application for the population. It also, this rule contemplates really restricting the use of audio only pretty severely in a way that we think is a real step back. We also think that the CMS could have been bolder in a number of different areas in allowing for greater flexibilities for the reimbursement of telehealth more broadly, something that we believe is within their existing authority. There are some technical issues. Some of the remote therapeutic monitoring codes have some really tricky parentheticals that require really double coding every time. And that's not going to be really practicable for the provider on the ground and for other medical professionals other than physicians to be able to take full advantage of this for the best interest of the Medicare beneficiary in question. So a lot of good in here, a lot of positive momentum broadly, but obviously we take some qualms with how some of the provisions are contemplated, and we'll be letting CMS know through our comments.
Yeah, and we will definitely be doing the same. I hear you. There was some definite good news there, some responsiveness by CMS to the stakeholder community with some concerns raised. And there's definitely some room for improvement. The good news is that we have the opportunity until early September to voice those comments and those improvements to CMS, and hope that they hear us. So that's great. All right. So before we sign off, I would be remiss if we didn't just touch briefly on some of the state of the states, right, when it comes to telehealth. Can you just give us sort of a high-level overview of some of the movement you're seeing in the states?
So much of what's happened at the federal level, like we've talked about, is temporary in nature. And really, the states are a great counterpoint to that. Over the last 2 years, the vast majority of states actually have updated their telehealth laws after the experience of the expansion of virtual care during the pandemic. So last year, in terms of the bills that we were tracking and we were supportive of, we saw just shy of 30 states pass positive bills into law that really leveled the playing field for telehealth, were tech neutral, didn't second guess the provider in determining the appropriate modality of care in terms of technology, that allowed for the establishment of a patient-provider relationship via virtual care, that expanded the flexibilities of delivering virtual care across state lines through the adoption of compacts or licensure registration laws, and also really continued the positive momentum in terms of some really commonsensical commercial insurance and Medicaid reforms that have expanded the number of Americans that had access to reimbursable virtual care through their insurance. That positive trend in those areas continues this year, perhaps not at as furious a pace, but we've still had just about 10 states pass positive bills into law this year. So we really cover all 50 states from coast to coast. That's no small task. The joke, of course, is for those that are in state telehealth policy, if you know one state's telehealth policies, you know one state's telehealth policies. It's very hard to extrapolate too many lessons from an individual state's experience, but obviously in terms of the trend, it's been overwhelmingly positive. And that trend has continued now for up to 2 years since the pandemic. We're just going to continue to monitor states, play a little bit whack-a-mole, and make sure that states don't do any backsliding. Just considering the sheer degree of progress we've made in 2 years, you can imagine how some of the folks that benefited from brick and mortar in-person care might think of putting up new obstacles towards virtual care adoption. So we've got to be very mindful.
Yeah, I mean, well, congratulations on the hard work, because I know that you have done a lot of hard work to make those things happen. You know, to be supportive of those things in various states, and it's a very, very heavy lift. So I know I appreciate it, and our clients appreciate it very, very much. I will wrap things up by urging our listeners to check out the American Telemedicine Association website, as well as ATA Action, to see, you know, if you want to get involved. There definitely are some good resources there. I know that there are special interest groups around particular aspects of virtual care, or remote monitoring or decentralized clinical trials that folks can join. And they're generally very substantive, I have found. So if you're kind of a nerd around this stuff like Kyle and I are, or even if you're just trying to get a beat on the industry, it's a great way to do so. Kyle, any closing thoughts?
Well, like you said, we would really love it if folks went to americantelemed.org and ataaction.org to look into the benefits of membership and the benefits of being part of our community. Also, of course, we're coming up on our second ever Telehealth Awareness Week, which is September 18th through 24th. That's got its own website we urge folks to take a look at, and there'll be lots of activities in terms of, special interest group open houses, webinars, and virtual and on-site events throughout that week with all of our partners. And so that's something that we've really got on our calendars that we're very excited to really spread the word about.
Yeah, that was really successful last year. I'm glad you raised that, Kyle, and I'm glad y'all are doing it again. All right. Well, thank you so much for taking the time to join us. And thank you to our listeners as well. Please join us next time for another episode of Decoding Innovation and Decoding Healthcare Innovation. How can I leave out the healthcare? And until next time, have a great rest of your week. Take care.